really exciting because for me it's a different audience, and I just want to talk about me for a couple of seconds, not very long. I'm an acute medical and stroke consultant, and I've been working as an expert witness over the last couple of years, but my background in the NHS brought me to work with coroner and coroner court for more than 4 or 5 years. I understand that medical cases sometimes can be difficult to understand in full, and especially when it comes to a very specific topic like can be stroke. But I promise you that by the end of the webinar, you will know majority of the information that you will find very useful in your daily practice. So I just introduced myself. As I say, I'm Bone Solon training expert in civil and criminal law. I work in Southampton University Hospital, which is a tertiary center, major trauma center, thrombectomy center, and Ashford St. Peters, which is a district hospital with all the challenges that working in a district hospital entails. I'm still in hospital, I'm working, and so I didn't want to show you my room, and I found this nice background. It's not a casual background that I choose, it's a special one, and this is gonna tell you something about me, because I spent some of my younger days in San Francisco, and specifically behind me that you can see the Golden Gate and Tiburon Hill. Tiburon Hill was where my boss at that time was living. It was this very, eminent professor, multiple research, very knowledgeable. He knew literally everything. And he had these habits to host us to his massive villa on Tiburon Hill, looking at the bay, San Francisco Bay, and he was inviting us for dinner. We were having, research chat. It was incredible experience. And then once he told us that we were going for a run. And we were, okay, fine, you are 65, we are 20, 22, 25. There's not going to be competition. And we were literally breathless, and he was running like there was a sort of marathon, and it was fantastic. The reason why I'm telling you this story is because there was for us a lesson about the importance of experience. Why experience helps? Experience helps because the core of clinical experience is not the store of knowledge. It's pattern of recognition built on exposure to variants. So a senior clinician is someone who can be able to recognize an atypical heart attack in a young woman presenting with a jaw pain, for example, or the anxiety, which in reality is a rare tumor, or a stroke mimic that felt wrong before scan confirmed it. So the experience help us to recognize the pattern that there is behind, the textbook presentation, and he help us to recognize the hidden problem that probably a person with less experience, a younger doctor, might be struggling to recognize, and especially give us the idea of crisis management, because in medicine, unfortunately, there is always the unpredictable, and the unpredictable not necessarily lead to breach of duty and negligence. So this afternoon today, we are going to explore the pathway of liability, causation, and the quantum behind a stroke case, and where it's most likely that a breach arrays across the stroke pathway, and how we can really differentiate causation for impossible to act differently in that circumstances. Obviously, the outcome of a stroke, as majority of us know very well, is the disability. And what does it matters in terms of result of a case? And then what you should look for when you want to instruct a stroke expert. So stroke, you need to consider something very simple. Stroke is equal time. Time in stroke is everything. Each minute count. I don't know if you ever noticed, I'm sure you have, the advert about FAST. FAST, I think, is very clever because FAST already, which is an acronym for actually neurological symptoms when we come to face, speech, arm, and time. In stroke, we need to be fast because each minute, 1.9 million of neurons without treatment are lost. So everything is around those minutes. We have specific, I just presented to you the time window, and I'm really concerned when I say that every minute is a legal event because we have the time of onset that we consider time 0 minute. And then we have all a series of targets that we need to meet in stroke to offer a patient a solution. Because the basic message in all this is that delayed treatment means higher risk of disability. So we need to have a target when the patient from his own house to the emergency door, and then from the emergency door to access to stroke care. Because we have a very specific time frame to offer the best treatment, which is 4.5 hours from the onset of the symptoms. After 4.5 hours, technically, the window to offer the treatment closes. So in stroke, when we will see together two different kind of stroke. The first part is going to be related to a ischemic event, which means when the blood supply to the brain is blocked. This situation is when these 27 minutes means everything. And this is when we are still in the time frame to offer a medication which is called clot bust. Sometimes we have reason why we cannot do that, but if we have the opportunity to do that and we don't do that, then certainly this is a legal event. So here you can find where the major failure can happen. And there is first things when we have symptoms which are not recognized, and therefore in hospital there is a delay at activating the stroke pathway. And then there is an event, for example, at triaging the patient because a low priority is assigned, which means that we always fail to miss the famous target door to CT scan at the thrombolysis window. At the same time, we discuss as the treatment window is 4.5 hours to give the clot bust. And if the treatment is not given, the question is why? And then obviously the clinical event is going to be resulting in a disability, which might be minimal disability, might be a catastrophic disability, such as hemiplegia, aphasia, inability to talk, to walk. Majority of people, they will struggle to go back to their own life, especially if they are a working age people. And something very, very different that happens nowadays compared when I was a young doctor is that in the past, 20 years ago, stroke was mainly recognized as a pathology of elderly people. These days, instead, we see people stroking at 22, 23. So while 20 years ago, a young person presenting with stroke symptoms was quite unusual, Today, instead, it's very likely to happen. The reasons are multiple. One is even, the abuse of substances, or sometimes the fact that the diet is not very good or simple as it was in the past. There's a lot of processed food, cardiovascular disease are galloping. So the background, the panorama of the stroke, uh, problem is certainly different from what it was from before. And there is a lot to discuss because this window that we see here, 4.5 hours to provide thrombolysis, in other country, for example, United States, is 3.5 hours window. But because we were missing a lot of thrombolysis due to the very short time frame, it was actually in Stanford University which started and say, oh, we should really prolong the window to provide a clot bust. And over the last 10 years, a lot of changes have been put in place to manage to extend the window. And majority of the UK region have now these protocols implemented, but not all of them. So when you take on a stroke case and the problem is the treatment window of thrombolysis, one of the questions that we should ask is, they've been implemented the extended hour window of thrombolysis, or we are still stuck on the 4.5 hours? As I say, it might be a procedural and contextual judgment problem, as we said before, not just the doctor, but the system. So I think that talking through an example is going to be the easiest ways to present you what exactly in a case something can go wrong. So we have a 50-year-old man, fit and well, no past medical history. And while he's at work, at 9:45, he developed severe dizziness and vomiting. Obviously, colleagues, they don't know what to do. They call 999 and describe in very simple but effective words. My colleague cannot walk in a straight line, is vomiting, is not feeling well. So paramedics arrive. They assess him with the GCS, which is an index very common in medicine, Glasgow Coma Score, to see if the patient is vigilant, if the patient can answer. And they notice then that he's got less speech, means that he can really talk very well. His word of they are just, they have some pronunciation problem, or they are slower, or he cannot find the words. And then they notice that the nystagmus, which is an abnormal movement of the eyes, is present. So we have 3 red flags. First things, I would focus your attention on sudden. Sudden is a key word because in stroke, we don't have any warning event. It's not a seizure, it's not a migraine. It's sudden. We were perfectly fine at 9:44, at 9:45, we have symptoms coming up. So the patient has got vertigo. The dizziness is described as vertigo. It's got the abnormal movement of the eyes, and it cannot walk along a straight line. So we say that he's got an ataxic gait. Means that he needs some help to walk, because otherwise he's going to lean right or left, or he's going to fall over. So where in all this we have the first fail at providing our care. So certainly I choose this example because it might be not a straightforward recognition of pattern, even for a medical trained person. Because in this case, with dizziness, ataxia, nystagmus, we are talking about a posterior circulation stroke. It means a stroke affecting the back of our brain. It's a less common stroke, account for 20% of the cases. And in this case, we have a problem with balance, coordination, vision, swallowing, and sometimes consciousness. And the structure of our brain, which are actually affected, are the cerebellum, the brainstem, and the occipital lobes, which normally are related to vision. Why is it so difficult at times recognize a posterior circulation stroke, which is a severely disabling situation? This is because symptoms of dizziness and vertigo very often are misdiagnosed as benign signs rather than a posterior circulation stroke, such as problem with our ear, labyrinthitis, viral illness, ear infection, or benign paroxysmal vertigo. And the first criteria, that one that paramedics, and we can see on the common advert on our street, they don't apply to posterior circulation stroke. And because the first criteria are negative, they provide us with a false reassurance that actually we are in a benign situation. Another problem, which it's a prerogative of posterior circulation stroke, is that patients sometimes improve. And we falsely believe that the patient is getting better. So we perceive a reduced urgency. And again, posterior circulation stroke is less frequent in general setting. So what happens is, as I can tell you, as attending the front door very often, every single dizziness is referred to stroke team. Of this single dizziness, only 50% is actually a stroke. All the rest are all the benign condition. And unfortunately, when they decide not to refer is where we miss the case. So it's complicated. It's not straightforward. It's not like black or white, like when we get a patient who is completely paralyzed on one side. In that case, it's less likely to miss it. So why the timeline we said is really important. So 9:45 onset of the symptoms, 10:22 paramedics arrive. They say, oh, it's fast negative. Yeah, but still got dizziness. It might be a posterior circulation stroke. They take him to hospital, then they triage in A&E like low priority. Because, oh yeah, it's a dizziness. It's a vertigo. It's benign. It doesn't have the fast symptoms. And then we start missing, minutes, and we delay and delay. And at 12:40, then the junior doctor seen it doesn't have any other neurological symptom. It's a vertigo, labyrinthitis. And when someone actually see it, it's too late. The CT head has been ordered 6.5 hours post onset. So we have 3 breaches at this point. Low priority assigned to the triage, misdiagnosis with as a positive or benign situation, and very delayed organizing of the CT scan, which instead in stroke, by guidelines, needs to happen within 1 hour from when the patient crossed the door. So this is certainly recognized in the NICE guidelines. So at this point, we are 6.5 hours. Can we still offer thrombolysis? No. We can offer thrombolysis because we have missed the regular window. Still, posterior circulation stroke, we say, is a special entity. And we still can offer a surgical procedure, which is called thrombectomy, when we retrieve the clot mechanically out of the brain. And for posterior circulation stroke, while for anterior stroke, we have a window of 6 hours extended to 9. For posterior circulation stroke, we have extended to 24 hours. But why time is so important? Because each minute without treatment, as we say at the beginning, we lose 1.9 million neurons. which for me translate in an extended damage to my brain, my patient brain. And do you want to have a visual effect? Or what does it mean, stroke extending damaging? So if you throw a stone in the lake and you have the circle, it's exactly the same. So the time just cause you an extended, more and more extensive damage coming up, the more time it goes by. So if we offer treatment the earliest possible, then we reduce the damage. We save as much as tissue as we can. The more we delay the treatment, the more damage we allow to progress. Someone might say, oh yeah, but he had the thrombolysis anyway. He had the thrombectomy anyway. Yeah, it doesn't really work like that. So if I give the thrombolysis, the clot bust, 2 hours after the onset, and the thrombectomy after 6 hours. Something else is if I give the clot bust a 4.5 on the dot, and a 9 hours of thrombectomy. In terms of, there are many variables, of course, which can influence the outcome, but ideally, all the guidelines, all the PubMed publication, all the medical literature says that the earlier intervention is the best intervention ever. As I said initially, the 4.5 hours window, they have now been extended in certain circumstances, which help us, for example, to still treat patients who arrives late because they live on their own, not because necessarily there is a breach of duty or delays at taking to hospital, but for multiple reasons. But we clinicians know that that very treatment, the very same treatment, is not going to be the same is administered 2 hours after the onset, 4 hours after the onset, and 9 hours after the onset. In my clinical practice, when I have a patient that I need to give the clot bust at 9 hours, I say, okay, fine. Do you know what? It's really pointless at this point. I can still give it to him, and probably I will do it, but it's not the same. There is a huge difference. Because, as we said initially, time is brain. 1.9 million neurons dead in every minute. So where there are these 3 failure points, because the nystagmus, the eye movement, was documented, but because the patient was fast negative, the nystagmus was not considered as, was not given the same importance as should have been given. And then there are a lot of pre-hospital scales where they are being put in place to actually trying to pick up this kind of stroke, which otherwise will be missed even more than they are right now. And because the paramedics didn't consider that the vestibular symptoms might have been a sign of stroke, they didn't do the stroke team pre-alert. So this was the first breach. Then the triage, it was categorized like non-urgent, which means that it will be seen within 30 minutes. But we know that in a very overcrowded A&E, 30 minutes, even for a category 3, is very unlikely to happen. So it was coded correctly, but it was triaged incorrectly. And again, the tests which were supposed to happen, which in this case are called Hint's test, which assess to see if these vestibular symptoms are coming from our brain or from our ear, it was not done. So the priority was even considered less. And therefore, the CT scan was ordered far beyond the 6.5 hours window. And when we realized that we were actually in presence of a clot blocking one of the major artery of the posterior circulation, it was too late because the lysis window, the clot bus window are closed, and probably even the clot retrieval has closed. Obviously, this is a simplified version, but certainly it's our majority, in the majority of the district hospital it goes. While obviously in tertiary center like Southampton, in my case, is just you are not so. We are not so entangled with this timing because we have the thrombectomy suite always next door. But if our patient arrive in a district hospital, like is my Ashford and St. Peter's Hospital, when then we need to transfer the patient, then it's even more time and more brain lost. So on balance of probability, how we might have got a better outcome. So what happened is that we delay the CT scan. We confirm too late that there is a clot in one of the major arteries of our brain. We have lost our window of opportunities, which means that patient is going to develop a very big stroke, and this level of disability will be higher. In this case, we use the modified ranking score at 3 months is going to be 4, severe disability. What should have happened instead? It should have had the CT scan within 1 hour. If the CT angiogram would have identified instead the thrombosis early, he might have received the clot bust, sent for thrombectomy, and the disability, which might anyway exist in this kind of stroke, certainly was not going to be 4, but it's going to be between 0, which means 0 disability, back to his baseline, to mild disability. So it's time is the certainly the most important and relevant thing. So we know that time is related to providing the clot bust, providing the surgical clot retrieval, and this is the reason why there are large audits in the NHS to see that the CT scan is done within 1 hour, how many people we offer the clot bust, how many people we send for clot retrieval, and what is the level of disability at 3 months. So again, the modified ranking score is something for you very, very relevant, because the modified ranking score is the link between the breach of duty, the causation, and the quantum. So the modified ranking score goes to 0 to 5. Actually, it goes to 6, but 6 is dead. So I didn't put the 6 on our scale. So modified ranking score is 0, which means the patient is back to normal baseline, perfectly fine as he was before. Then we have the expected outcome. It might be 1, minor symptoms, minor dysarthria, minor weakness. It's a stroke. Some tissue was lost, and obviously there are a spectrum of outcome which are related to even to the baseline of the patient. So I make you an example. It's not that if the patient was walking with the stick before the stroke, and then he suffered from a stroke, we offer the clot bust and the thrombectomy, the patient becomes 0 symptoms. No. The baseline is really relevant. And this is very important for you. If you are presented with a case, with a patient suffering with a stroke, but the patient is severely morbid before, with a lot of comorbidities and extremely frail, living in a care home, poor mobilizing. My suggestion is that those cases, they don't go anywhere, because we don't have the power to make these people better, even if we offer care which are absolutely gold standard. So when you pick up a case, you need to look how the patient was before the stroke. That's a key point in your practice. Don't just because family tend to say, "Oh, they missed the window. The hospital did this. The hospital did that." It doesn't work like this. If the patient was very frail, we don't have the power to save him or her. It's going to be mission impossible. I see many patients, especially now in certain area of the country, the average age is very high. So the patients got time to develop cardiac comorbidities and kidney comorbidities or lung comorbidities. These patients, they don't do well anyway, even if they are provided with very good care. To be realistic, to offer gold care, it's nearly impossible in the current NHS situation because of how many people we see, but good care can be offered. However, again, offering good care to a patient who's got very, very severe comorbidities sometimes is not enough, because I've seen many times in my clinical practice, like a stroke is probably the final event for certain patients. But if we have a patient who is fit and well, as our example, 58, fit and well, working, modified ranking score 0 as a baseline, and then he ended up with a modified ranking score, that's obviously a different story. So there is, as you can say, the general damage, pain, suffering, loss of amenity, loss of independence. A patient who cannot walk anymore is certainly your target. A patient who has lost his independence is certainly your target. Then patients who are employed, there is the calculation for working time, the pension that they lose. And the problem is the amount of care that they need, because I've seen only few people dying directly from stroke. They die from comorbidities, and they die according of complication they develop, which are mostly related to the severity of the stroke. And the problem with these this category of patient, is that they require high level of care package. So very often they cannot be back to their home because they need special chair, they need 24-hour care, they might have a tube for nutrition. It's very complicated, and they ended up in a nursing home. And they require physiotherapy, speech therapy, occupational therapy. Sometimes if they go back in their own environment, house adaptation, and special equipment, bed, chair. Then we have all the equipment to mobilize them from the bed or to the chair. Is really complicated and certainly very expensive. So this is, I think, it's a very good overview of the ischemic stroke. Then instead we have another entity, the opposite entity, which is certainly known as hemorrhagic stroke, when the brain is not doesn't suffer with a cut in blood supply, but it's got a broken vessel which causes a blood collection inside the brain parenchyma, inside the brain itself. In this case, thrombolysis is certainly not an option. Is actually, we need to be sure before we provide thrombolysis that there is not a drop of blood in the brain of that patient, because otherwise the consequences will be catastrophic and we will see the patient dying. I believe that in all these, radiologist has got a very important role, because very often, especially young stroke consultant or not very experienced stroke consultant, before providing thrombolysis, they wait for a formal report. And my experience is that medical legally, it's always more, it's it's a prudent attitude to wait for the formal report, because a stroke consultant is not a radiologist trained consultant. We see a lot of scans, so it's very likely that an experienced stroke consultant can read a CT scan or a CT angiogram. But medical legally, if something happened, the question would be, why didn't you wait for the formal report from radiologist before you offer thrombolysis to this patient? Believe me, in medical practice, it's something is very common, and it's not so simple because, as I say, there are many nuances to the aspect. One of the nuances is because you don't want to wait, as we said before, we thrombolize a patient. But my advice is better and safe than sorry. So if we are not sure of what we are looking at, leave the receiver, call the radiology and say, excuse me, please, I'm really this is a matter of urgency. Could you report this CT scan? Can you tell me if there is no blood? Because I need to provide a clot bust. And if there is even a drop of blood, the patient might be dead after I provide the thrombolysis. And something very, very important, always coming from experience. Sometimes the patient, especially elderly patient, they fall. No one knows that they fell actually before coming to hospital because they were found on the floor. In that case, it's always clever say, okay, 1 second, let me take a step back. Yes, I want to provide the clot buster as soon as possible, but this patient fell. Is it cautious to wait for a formal report? Is it cautious to liaise with the radiology and say, okay, hold on, can I do this? Is it safe? Because I don't know if the patient hit the head. How can I know that? It happened once. It was a personal experience. The patient arrived with a stroke. The patient was coming from a care home, and they didn't tell us that the patient had fallen. The patient couldn't tell us because he was not verbal at the time due to the severe stroke. And obviously, we thrombolized because we didn't know. There was no blood, visible blood on the CT scan, so that was done according to the old criteria. And then when there was the coroner inquest, the coroner inquired the care home, and in a tiny, tiny remote entry, there was a tiny, tiny remote entry from the care home and say, oh, the patient fell 2 days ago. They would be quite honest to tell us, because obviously we might have said, okay, fine, we don't really know if there is a tiny and invisible bleed, and the thrombolysis in this case might kill the patient rather than make it better. So as I say, this is where the experience comes in. But when we have majority of the hemorrhagic stroke, they are quite visible. You will see this massive amount of blood then clearly on the CT scan. And the cause of intracerebral hemorrhage, majority is related to high blood pressure. And this is something that you need to be careful with, because blood pressure management happens in the community. So it's true, majority of patients are quite reluctant to start medication very early. But currently, we have on our ward a 27-year-old lady who was hypertensive. She was prescribed her medication. She took the blister, the blood pressure came down. Then she didn't renew the prescription because she thought that the problem was solved. And then she ended up with a catastrophic bleed, severely now impaired. She's only 27 and she will never recover. So in this case, sadly, in the community with the GP, there is a breach of duty of failure to inform the patient of the risk of untreated hypertension. because we know that hypertension is the serial killer, not for ischemic stroke, but for hemorrhagic stroke for the majority. The presentation of intracerebral hemorrhage is very different. Normally, the patient loses consciousness or is very confused. He's got a sudden headache. Normally, we see the patient holding their head. It's quite specific. It's quite descriptive as they come. And obviously, it can mimic an ischemic stroke. So please, first things, request for a CT scan. And if the CT scan doesn't show anything, then it's fine. But majority of the time, it's gonna come up with a white lesion. And again, the legal relevance is the timing of the blood pressure management. Over the last 10 years, we are managing a lot of intracranial hemorrhage, which were related to the use of anticoagulation. Anticoagulation has very, very common drugs used for majority by cardiologists. And unfortunately, people who fell of spontaneous hemorrhage, they are contemplated side effects. Clearly, we use them because the benefit coming from them are majority than the risk of using them. And there are obviously extensive research market projects we show that it's safe to use them. But still, this is relevant to know. And we need to use the reversal in that case. So we need to provide an antidote for that. But another important entity is the subarachnoid hemorrhage. The subarachnoid hemorrhage comes from the 85% of the cases from the rupture of an aneurysm. So many people are born with a little, a weak vessel, and there are some circumstances, and I've been doing a lot of work on this, especially during pregnancy. Young women, they can have a rupture of this aneurysm because during pregnancy, we have an increase of the blood volume. So this little weak wall, they cannot hold this massive pressure and they simply pop. And a woman comes to emergency department and say, oh, got a terrible headache. And they say, oh, it's a migraine. Well, hold on a second. This woman never had headache in her life before. Why she should develop headache during pregnancy? No, it doesn't work like this. She needs to be investigated. And nowadays, you can scan pregnant women because the risk of dying from a ruptured aneurysm is extremely elevated. Or sometimes they present like the worst headache of my life. And this subarachnoid hemorrhage can be quite subtle and misleading. And it's very clear to see. We had a case today. It was perfectly showing on the CT scan. Sometimes it's very subtle because the rupture of the aneurysm is not sudden. It's like a little fissuring in the wall, and they drop. There is just this dropping of small amount of blood. In this case, you need to provide a lumbar puncture. So if the patient has got a thunderclap headache, the worst headache of my life, and the doctor recognizes that this might be a subarachnoid hemorrhage, that they need to do a lumbar puncture and they need to do it immediately. And again, I had a case where the lumbar puncture was not done because the lady was pregnant. It's not a contraindication. Pregnant women are exactly the same patient as non-pregnant women. But if you miss a diagnosis, these are mortality risk. Here the patient died. There is no disability. Here the patient died. So how can minimize the damage in intracranial hemorrhage? First things, we need to treat the hypertension. In ischemic stroke, we have time to reduce the blood pressure within the first 24 hours. In intrahemorrhagic stroke, we need to reduce the blood pressure within 1 hour. I can show you that is the most complicated things ever. It's with all the effort, believe me, it's really difficult to achieve because the majority of these patients, they don't have a raise of the blood pressure overnight, but they have a long-standing blood pressure. A long-standing high blood pressure is problematic to reduce, in a blink of an eye. It takes time. So we struggle to reduce this, and there is a lot of work in the NHS, in the stroke unit, to try to improve this. But as an experienced clinician, you might tell me, oh, you didn't reduce the blood pressure within 1 hour. And I might reply to you, I tried. The problem was that the blood pressure has been untreated for very, very long time. So I had no way, and I have plenty of literature to show you that I couldn't. So obviously, if he is not treated urgently, that's a different story. Or if the inadequate agent is chosen, that's another different story. So we can try to achieve that to the best of our, competence, but we might not be able to. In that case, there's no negligence. So it's important to see the timing of the intervention. The reason is because if we don't reduce the blood pressure, the blood will expand in the brain and the patient will deteriorate. When it comes to anticoagulant, on this one I will be very, very quick because it's just for your knowledge. Then we use the anticoagulant, which are medication to prevent clot formation, to actually prevent an ischemic stroke. But if an hemorrhagic stroke happens and the patient is on anticoagulant and we have a lot of agent, it's important that we choose the right one. Some of these reversal agents, especially in the central column, you see direct oral anticoagulant, which are now very, very common. They are not available in the majority of the district hospital pharmacy because of their price. So this is something that obviously becomes a contextual judgment problem because we don't have it. So if I have a patient like this, I certainly can treat it with some other agent, but probably I won't be able to offer the right one. So in that case, how can you, it might be more a network problem, might be a hospital problem rather than clinician problem. So there is the nuance of the anticoagulant is very, very wide and quite fascinating actually. But again, for your knowledge, is when you approach a case, you say, okay, fine. It's in which context there was a delay, they didn't do it, or they couldn't do it, because this is relevant. So again, if we don't reverse, the hematoma might expand, especially if the blood pressure hasn't been treated. So availability and timing are both legally relevant because we know we can see that how there is early expansion and if we delay 1 hour, 4 hours, the volume might become 2 or 3 times bigger. And if if we don't treat at all, sometimes the patient might die because there's so much pressure within the brain. But having said that, if the patient arrives too late, for example, because he was at home, he was found after 12 hours, last time seen one, there's no point to reverse because at that point it doesn't work anymore. So there are many factors that you need to take into account. Having said that, I will conclude my presentation by just a very quick recap that ischemic stroke and hemorrhagic stroke, both of them are related to timing because we lose function brain and disability. The more time passes by, the more likely is the patient will suffer with severe disability. It's important the context, which hospital we are working with, Are we in Southampton? Are we in Ashford and St. Peters? It makes difference. And we are obviously the NHS is trying to equalize care just to offer each patient good quality care and standard of care. Sometimes it's not possible. We see a lot of problem related to ambulance timing, for example. And for you, it's important to have a specific clinical profile of the patient because, as we said, different problems in a patient who's normally fit and well, different problems in a patient who comes from a care home. And the prognosis is related to functional status as well. A patient who's got a cardiac problem is very unlikely that we will make a full recovery because the complication might be too severe. And obviously, then if the patient survives, you need to take into account the care, rehabilitation, equipment, all these, and job loss. So it's important that we see not the stroke as an entity, but the patient as an entity. As a clinician, this is what we normally do or should do daily. Thank you for your attention.
Thank you so much for that, Cristina. That was absolutely fascinating. I think everyone's learned a lot today. We've just
I
had
hope so.
we just had a couple of one comment and one question. A comment from an ITU consultant, a neuro ITU consultant, who said it's not uncommon to have patients by the end of their stay on 5 antihypertensive agents, and when they were admitted to the ITU from home, they were on none.
Yeah, exactly. So I believe that there is a lot of work that needs to be done in the community because when it comes to cardiovascular disease in general, not only stroke but even heart attack, looking at the clinical profile is really relevant. And if they don't, so the GP, they should really clear pass the message that the medication are not just because we like prescribing. We try to tackle a problem with, and as I say, silent killer because we don't see the damage from diabetes, from high blood pressure. We don't see the damage of untreated blood pressure. And ITU knows better because, as I say, my 27-year-old ended up in ITU for a very long time. And they struggle to bring down the blood pressure because she has been hypertensive for such a long time that they couldn't really help her out immediately.
Yeah, I understand. We've had a question. Someone has asked, I've got a case where my client has arrived with severe bleeding hemorrhoids. So they stopped the anticoagulants and she suffered a stroke as an inpatient. Would you see that? I mean, possibly you need a bit more detail, but would that be a negligence case, do you think?
So this is when the context becomes very important because if it is a severe bleeding which actually is dropping the hemoglobin level, certainly is something reasonable to stop the anticoagulant. The problem is for how long they stop the anticoagulant. Because if then or sometimes they say why they didn't consider a surgical procedure to stop the hemorrhoids bleeding. It's because, again, everything it's a risk profile. The patient is on anticoagulant because he's a high risk patient, not because obviously we want to prescribe an anticoagulant and say, oh, yes, we're giving this for fun and we hope you don't develop a stroke on this. No, there are specific criteria to use the anticoagulant. So stopping them. And we have the hematology guidelines. They are very precise on which cases we should intervene. And my experience is that these cases needs to be monitored very, very closely.
Thank you. Someone's just asked, are there any absolute criteria for referral to the stroke team from A&E for FAST? Say, for example, patients who present with dizziness or vomiting, as many cases arise from a failure to refer at that stage.
Yeah, this is a problem, I have to say, because dizziness, I pick up this case because I had two experiences actually. They were quite relevant for me. one experience was this gentleman who had been off balance for a couple of days, suffering with dizziness. At the same time, he had a chest infection. So when he was taken to hospital, they obviously had low level of oxygen, and their priority was focusing on the respiratory symptoms. But they realized that he couldn't speak very well, and for some reason, they missed this. And when they noticed at some point, 24 hours later, that the patient couldn't swallow. So they say, okay, what's going on? So they did an MRI and they found a small posterior circulation stroke, which are really, really bad. And the patient, in the end, a 6-year-old gentleman, ended up with modified ranking score of 4, severe disability. And then the wife sued the trust. The problem was, however, in all these contexts, yes, that someone in emergency department missed a stroke. However, the patient was with morbid obesity. He had a sleep apnea. He was not using the CPAP, and he had an hypertension which was uncontrolled. So all these comorbidities before, and on top he arrived outside of the thrombolysis window because he arrives 2 days later. And as I say, in this case, it's difficult that they will win the case and they will have 2 million in compensation, because the patient was already with a poor baseline from the beginning. The second case was actually, we were discussing this afternoon, was one of my young junior doctor was referred this gentleman with dizziness and vomiting. And he said, okay, have you done the HINS test? And he did say, no, we haven't done it. And my junior doctor said, okay, do it and then call me back. I was passing by from emergency department for another reason, and I saw this man. And it was a first glance that I did realize, but just because I'm old, that the patient was suffering with a stroke. It was not the normal dizziness. So I picked on the 4.5 hours window. I didn't thrombolyze him because he was on anticoagulant, and he didn't have a clot that I could send to retrieve. But it was something that I discussed with my junior doctor, and I told him, please, next time that someone call you, please go and just eyeball the patient. Just because we can't say without seeing. So, there are many nuances, but the bottom line is you can make a genuine mistake. And the genuine mistake, if it's done with all the criteria, seldom is a breach of duty or causation. But if you don't go and see the patient, if you don't do all the relevant tests, then someone can argue with you that you didn't do those things. And it makes a difference.
Lovely, thank you. I think we've just got time for one more question, if that's all right. So let's go to Dr. McCadden. Is there evidence that stroke rehabilitation reduces MRS by a defensible value?
Yes, but it depends on the baseline. If I have a young man who suffer with a stroke, and we say that the time to rehabilitate someone in stroke is 18 months roughly, because it's in 18 months that we have the possibility to help the brain with intense rehabilitation, to rewire, because we normally have two hemispheres, so there might be a quite good compensation. Normally there is an improvement, but if the baseline is poor, then the rehabilitation is going to be very, very limited. I had recently a case where a patient was young, 62, but very poor baseline. The family wanted absolutely for me to send him to rehab. And I explained to them, I can send him to rehab, but his heart is weak. He won't be able to tolerate such an intense rehabilitation. And then I was helped by the rehabilitation consultant say, I'm sorry, we have poor chances that this man, despite the age, might be suitable for rehabilitation. But if the baseline is good, certainly rehabilitation reduces the modified ranking score.
Lovely. Thank you again so much, Christina. That was just we've had some really lovely feedback sent through on your presentation. And what we're also going to do is, in addition to the recording, which we'll share this week, is we're going to do some key takeaways as a document that we'll share with everybody who registered as well. So we'll do that in the coming weeks. And there's a few questions we didn't get to, so I've made a note of those so we can address them directly. So
Uh,
thank you.